All right, so we're excited to have Andrei Pop on. He is the System Structural Director for Ascension, Illinois, and he'll be talking to us about a recent paper he wrote on the lifetime management of aortic stenosis. Go ahead, Andrei.
Hayden, thank you so much for having me. This has been a labor of love for myself and the Columbia crew. Worked very closely with them on this paper. Um, this is the paper. First author is Shmuel Chen. The senior author is Isaac George, and also we collaborated with Lakshmi Prasad Dasi from Dasi simulations. This is published in the Annals of Thoracic Surgery, and the genesis of this was we felt that there's an opportunity to kind of provide a framework for lifetime management of aortic stenosis. People always say lifetime management is important. Everybody kind of knows what the principles are, but we felt that we need to put things together and try to provide again the framework on which to build. I don't think we have all the tools we need for this, but I think the tools will be forthcoming. This is what we define as lifetime management, which is a individualized aortic stenosis management aiming to limit the sternotomy number, minimize the lifetime procedural risk, and maximize quality of life. And I think the emphasis needs to be on individualized because we don't want to have the one size fits all approach. As you know, recently there was a lot of angst over this paper that showed that in the
Yep.
US a couple of years ago, almost 50% of patients under 65 were getting TAVR. And I think part of the angst is misplaced because none of these patients were treated by individual doctors. They were treated by teams of physicians. And those teams decided that maybe TAVR was the best treatment for that particular patient. The other reason that I think that the angst is misplaced is that it's a small minority of patients of those who get isolated SAVR or isolated AVR who are under 65. So this is predominantly a disease of the elderly.
Sure.
Um, the the other thing that's important to remember is after COVID brought the U.S. life expectancy down, people in the U.S. actually live a fair amount. If you're 79 and you're a man, you have 8.25 years of life. If you're a woman at age 82, you have 8 years of life. You actually have to be way past 100 to have less than 1 year of life expectancy. So I think people are living a long time. In other countries, they're living even longer. So I don't think that the age recommendations that we have in the ACC/AHA guidelines make a lot of sense beyond the fact that we really don't have randomized good quality data for TAVR in patients under age 65. So even though the guidelines do talk about life expectancy of more than 20 years or less than 10 years, we feel that life expectancy is going to end up being a lot more important than the overall age of the patient. Um, the other argument that's being often heard in lifetime management discussions, especially from the surgical side, is, well, once you get SAVR, your life expectancy is not that long. Surgical valves will last 10 to 20 years. These people don't live that long. And a lot of times they quote data from Sweden. And if you look carefully at this study from Sweetheart, basically the patients who were sick and high risk didn't live very long, but the patients who were young and healthy actually had decent life expectancy. A lot of them lived more than 10 years. And this is also supported by US data from New York State that shows you that young people, 50 to 69-year-old in age, who got either bioprosthetic or mechanical valves, actually had pretty good survival at 15 years. 60% of them lived more than 15 years. So it's very important to think of lifetime management anytime you put a valve in, whether it's a surgical bioprosthetic valve or whether it's a TAVR valve. This is the data from Sweetheart, which shows you that the people who are young and low risk, 17.6% of them were dead at 10 years. So a lot of them survived, whereas the people who were sick and old did not survive. So if you're young and you're otherwise healthy, you're going to live a long time after surgical AVR. Obviously, the thing that we all struggle with lifetime management is repeatability. So we feel that everybody should have the ability to have a second valve in their lifetime. Even if you're 99-year-old, your valve, let's say you're doing a TAVR, the TAVR could implant high, the TAVR could implant too low. The valve maybe has a problem. Maybe you tore the leaflets when you did a valvuloplasty. Maybe the patient didn't take their aspirin and the valve thrombosed early. So I don't care what a patient's age is, you need to think of the ability to put a second valve in them. And this is basically what the literature says as well. We should now shift the focus from the first valve to the second valve, and that is the treatment of bioprosthetic valve failure. And obviously, that has to take into account the first valve as well. So that's kind of been our brief in putting this paper together. And we know already that TAVR has changed the SAVR landscape dramatically. This is data from Emory that shows you that the patients who get isolated SAVR have lower STS prong, more bioprosthetic valves, larger valves, more annular enlargement, and lower in-hospital mortality. And as a matter of fact, even though people say that TAVR really killed the mechanical valves, the mechanical valves were killed by the surgical bioprosthetic valves. And actually, the biggest drop in mechanical valve use happened before TAVR became available. And since TAVR has become available, there has actually been an uptick, which I think is appropriate in the use of mechanical valves. So the other thing that's important when we talk about lifetime management is to choose the right procedure for the patient's level of risk. If you have a valve like the one on the right, which incidentally was in a 60-something-year-old, this is a bicuspid valve, I think you have to have a damn good reason to do TAVR in this anatomy. This is a
That's
patient who can have SAVR, they will do very well with SAVR. On the other hand, if the patient has, is inoperable, obviously we'll do whatever it takes. There are patients who have chest irradiation who are super high risk for SAVR, but are very appropriate risk for TAVR. So I think it's very important for the valve team to be honest with themselves and select the complex procedures that are appropriate for the patient. If you're high surgical risk, then look at TAVR. If your TAVR is going to be complex, look at surgery and vice versa. The other hypothesis we introduce in the paper is this concept that Isaac generated, which is the TAVR first hypothesis. And this is basically a way to test biological compatibility for selected cases. We know we've all seen surgical bioprosthetic valves that have failed at 5 years, at 4 years. And then there are case reports of surgical bioprosthetic valves that have lasted 30, 40 years. And so we don't quite understand what drives that. We know end-stage renal disease is bad. We know probably if you're younger, it's bad. We know if you have parathyroid issues, it's clearly bad. But beyond that, we really don't know what drives durability in surgical valves. But we know that overall TAVR and SAVR valves seem to have similar durability, but individual patients respond differently to biological tissue. So the TAVR first hypothesis, and maybe this will be the most controversial aspect of the paper, is that if you have somebody young who may not want mechanical valve now and who would like to avoid a sternotomy, you can give them a TAVR valve. If that TAVR valve fails in 5 years, then you know it's time for them to get a mechanical and they're done. And you're operating on a virgin chest. If, let's say, this 50-year-old patient gets a TAVR valve and that TAVR valve lasts 10 or 15 years, then you have a very strong argument to either give them another bioprosthetic valve, surgical, or TAVR the next time around. So this is something that is a hypothesis, is not yet tested, but this is something that I think in individual cases can be utilized already. And I'm actually planning to post on Murmur a case that we did in mitral position yesterday, where this came into play very much. So one idea for us was to try to take an individual patient and to figure out what their life story could be, depending on the strategy you take. Let's say you have this 50-year-old patient and you give them a biological SAVR valve, and that fails early, and then you give them a mechanical AVR, then they've got 2 sternotomies and they have to be on anticoagulation. If this same patient gets a SAVR valve that lasts a long time, then for the time that they fail, they can get a TAVR, and then they have 1 sternotomy. You can explant the SAVR and you give them 2 sternotomies. Alternatively, if you give them a load frame TAVR valve, which would be easy to explant, that valve fails early, then you move to mechanical, 1 sternotomy in their lifetime, and they stay on anticoagulation. If the TAVR valve lasts a long time, you do a TAVR in TAVR, they get no sternotomy, they're doing great, or you explant and then you do a SAVR and they end up with 1 sternotomy. So this is kind of the concept. This should be tied with levels of risk here. Those levels of risk are not yet easily calculated, and I'll show you why not. But this is kind of the framework that we think you should apply to every individual patient, acknowledging the fact that there's going to be uncertainty. We don't know, for instance, how long the first biological valve will last. So TAVR first would be appropriate in patients trying to avoid a mechanical AVR or anticoagulation. Other patients would be, let's say you have a young patient, I don't care what their age is, and they're waiting for a kidney transplant. We know patients with mechanical valves do really bad with kidney transplant. You give them a TAVR, they get their kidney, then when the TAVR fails, you do their 1 lifetime sternotomy. Also in patients with bicuspid aortic valve and dilated aortas that maybe don't yet justify the replacement of the aorta. If you give them a TAVR, whenever that fails, you can hopefully by then replace the aorta and the TAVR. If that doesn't fail and the patient needs just the ascending aorta done, then the ascending aorta will be done in a virgin chest and you leave the TAVR valve alone. This concept of lifetime estimated risk is a new concept for the lifetime management of aortic stenosis. And basically is the idea of putting together the cumulative risk of all valvular procedures, TAVR and SAVR, in a patient's lifetime. Obviously, you would try to calculate that using the STS calculator and the TAVR in hospital mortality calculator. The problem is both calculators have limits. The STS calculator doesn't give you a risk for TAVR explant, doesn't give you a risk for root enlargement or root replacement. And pretty much everybody in the field feels that those surgeries are going to be critical for lifetime management of aortic stenosis. On our side, on the TAVR side, there's really no calculator for Basilica, for Snorkel, for Unicorn. There is no calculator for TAVR in SAVR and TAVR in TAVR, and there's no calculator for alternative access. So these are tools we need to develop rather quickly, I think. So how do we build the lifetime management pathway? Well, we know that if you have a good quality CT, you can predict the size of valve that a surgeon would implant without root enlargement or root replacement. And that is very accurate, as shown in this graph. The surgeon will either put a smaller valve than what you expect or put the same size valve that you expect based on CT. They will essentially never put a larger valve. So if you have this information, you can calculate the risk of PPM based on the standard tables that are published for surgical valves. So then you will know whether your patient will have PPM or will not have PPM before you enter the operating room, and you can adjust your surgical strategy in accordance. So this is the basic algorithm in our paper. we start by talking about a life expectancy of greater than 8 years. If you don't have 8 years of life expectancy, the ACC says 10 years. If you have don't have 8 years of life expectancy, then probably SAVR needs to be out because you'll probably do just fine with TAVR. If your life expectancy is less than 1 year, then you go palliative care. If your life expectancy is more than 1 year and your anatomy is good for TAVR, then you go to TAVR. If your anatomy is not good for TAVR, then either you talk SAVR or you talk palliative care. On the other hand, if your life expectancy is good, more than 8 years, you look at whether the patient is suitable for TAVR and has no other indications for surgery, such as CABG or aortic aneurysm or whatever. If the anatomy is not suitable for TAVR, then you're asking yourself, are they prohibitive surgical risk? If they are, then you're done and you're palliating. If they are prohibitive, if they're not prohibitive surgical risk, perfect sense to do SAVR. On the other hand, if the anatomy is favorable for TAVR, and they are prohibitive surgical risk, then obviously you go to TAVR. And if they are not prohibitive surgical risk, then you quantify their level of risk. These are the patients really who can have either TAVR or SAVR. And then you make the decision based on the decision pathways that we are presenting together with patient preference, because I think that that's going to be a very important point in this discussion. Patients get to choose or at least get to express a strong preference. We feel that the patients can't make you do something you don't want. You can't make them do something that they don't want. But there's a large space in the middle where we can meet and where patient preference certainly has to play a role. And the guidelines recommend that as well. So we broke the pathway into two different pathways, one for the surgical AVR. We recommend that every patient start with a CTA. You get all the standard measurements. You estimate what surgical valve size would go in, and you determine the effective orifice area that the patient will get you, that the valve will get you. If the patient is at risk for patient-prosthesis mismatch, then you estimate their level of risk for aortic root enlargement or replacement. That is going to be highly surgeon-dependent. The data in the literature is a bit contradictory. Some people say the level of risk is not higher than a regular AVR. Some people say it's a lot higher. So if the surgeon estimates the level of risk is acceptable, then you go to aortic root enlargement, aortic root replacement. If they say that the level of risk is increased, then you go to either a TAVR or potentially you go to a mechanical, or potentially you send the patient to a center that maybe has more experience and is more willing to take the level of risk on. If the patient has no risk of patient-prosthesis mismatch, then you evaluate their potential for both TAVR and SAVR, and you evaluate the ability to redo TAVR and SAVR. Because the last thing you want to do when you're doing the first and hopefully last sternotomy in the patient's lifetime is to commit them to a redo sternotomy when their surgical valve fails. And the same thing with TAVR. If you're putting a valve in there that will have to be explanted and you will not be able to get a second TAVR in, then maybe TAVR is not the right thing to do when you're starting out. On the TAVR side, you do the same measurements, and then you look at TAVR complexity. If the complexity is going to be high, if there's going to be a highly complex, difficult TAVR like the one that I showed you, then you really should talk to your surgeon about considering SAVR. If the SAVR risk is acceptable and the patient is a complex TAVR, by all means go with SAVR. If the patient is at increased SAVR risk, then we use all the risk mitigation strategies that we know, snorkels, basilicas, whatever. If the TAVR is standard complexity, you choose a TAVR valve, whatever vendor you want, whatever size you feel is appropriate. You estimate the potential for redo valve-in-valve TAVR, and if they are redoable, then go ahead and do the TAVR, and you know that the next time around you'll put another TAVR in. If they're not able to be redone, this is probably the time to do surgery and do the surgery in such a way as to be able to get them another valve in the future. So finally, we came up with these principles, which I think are important. I think all the good experienced surgeons that I met around the country and around the world will tell you that They agree that gated CTA and multidisciplinary valve team consultation should be obtained for all patients getting a biological AVR, whether that's TAVR or SAVR. As you know, right now it's mandatory for TAVR, it is not mandatory for SAVR, and I think that's a problem. We should try to get everybody done with a single sternotomy. We shouldn't commit patients to 2, 3, 4 sternotomies in their lifetime. Do the surgery, especially if it's going to be complex, at the age where the patients are best equipped to tolerate it. If the patient is going to need massive root surgery, you don't want to do that at age 80, you probably want to do that at age 60. Life expectancy, we feel, outweighs the level of risk. High quality AVR is essential in the young. Something that's tolerated in a 90-year-old, though they have some perivalvular leak, they have this, that, and the other, is not going to be acceptable in a young person. In a young person, you want to have as pristine a result as possible. Lifetime estimated risk should be considered besides the immediate procedural risk. Patient anatomy and lifetime estimated risk should guide the type and sequence of interventions. TAVR first is reasonable. Low frame valves are favored if TAVR explant or valve-in-valve TAVR is anticipated. Avoid high-risk procedures. Any patient may require a second valve in their lifetime. And if the anatomy would preclude you from doing a repeat TAVR in TAVR or TAVR in SAVR, or you have a high risk of PPM with standard SAVR, then do a root enlargement if you have local expertise. Refer to a comprehensive or level 1 valve center for root enlargement if you can't do it locally. You could put potentially a mechanical valve. It's less surgery, and at least you know that the patient will not need another valve in their lifetime. And finally, TAVR can actually help you mitigate some of the risk of patient prosthesis mismatch. So I think that's it.
Well, that was awesome, Andre. I mean, I think, we see these patients all the time in clinic, and I think that's a pretty amazing tour de force on how, we can try to approach these patients and put them in a context to get the right valve and, surgery versus TAVR. So a couple comments I had. First of all, I looked at your 8 years. I was a little bit curious how you came up with that, but, going through that first slide and the age and how long they're expected to live, it does seem that kind of mirrors the guidelines. It's kind of around 79 and 80 years old. So that's actually not too far off the guidelines. So, I do think that's a pretty good thought. And then looking at the CT, I think, ahead of time before you make these decisions and, gauging the risk of PPM on the one side versus, the complexity of TAVR, I think is really important if you have a patient that could go either way. So do you have a CT together? How do you approach it? Do you have a CT when you see him? Do you see him with the surgeon? How does it work again?
So for us, we have agreed that if a patient is referred to the surgeon, they're going to get a TAVR CTA, and we're going to discuss them in valve conference. And I think that's very reasonable. And I think, again, when people say, well, are you doing TAVRs in 50-year-olds? Are you doing TAVRs in 60-year-olds? Are you doing TAVRs in 40-year-olds? Yes, we've all done it. There are those patients who need it.
Sure.
And generally, they're not patients that come to your clinic or my clinic. They show up at a surgical clinic, and the surgeon doesn't want to operate
Sure.
for whatever reason. And so we think that all patients deserve this multidisciplinary consultation. There's no reason not to have the multidisciplinary consultation. I'm not going to go to the patient and convince them that they need TAVR when they present to the multidisciplinary team, but I might have a discussion with my surgeon and say, well, if look at the coronary height. If you're putting a standard supraannular valve in here, we think you're going to get a 25 in there, but the sinuses are 26 and the coronaries are 8 millimeters high. After you put your supraannular valve, those coronary heights are going to be lower. How am I going to do a TAVR in this patient in the future? So that kind of discussion, I think, is important. And I think, the surgeons that we work with freely acknowledge that they don't lose anything from getting the CTA. And a lot of times they find all sorts of interesting stuff that changes their approach. So I really don't think that it's a major expense and it's a major problem to get a CTA. I don't know how it's in California, but in Chicago, if you sneeze and you show up in the ER, you're going to get a rule out PE CTA. So I think that really this does so much for the patient that we should do this standard in everybody. And that's what we're trying to do in every case.
Yeah, no, that's great. We're trying to move to that. It's a little bit hard in where I'm at with all these different insurances and stuff. So a lot of times I'll see him, I'll talk to him, I'll say, hey, let's get a CTA, get an angiogram, and then we'll kind of get back together again and have him see the surgeons. But really before I can have a good discussion, I need to see the CT because I can't tell a
Absolutely.
patient, how they look for TAVR until I see the CT. And like that case you showed, I mean, if you have a bicuspid valve like that should really be surgery first, unless they're absolutely inoperable. The other question I had, younger patient I saw today, maybe 71, 72, but also has AFib. I don't know the coronary status, but there is the concept of when the surgeon goes in there, they pop the hood. There's a lot of different stuff they can do. They can do a maze. They can do clip the appendage. How do you take those other potential surgeries, into account?
Yeah, we definitely take it into account. And, it wasn't an AS case, but recently we had a patient that he was older, he was in his 70s and had a massive ASD and had atrial fibrillation. And by the way, the tricuspid valve was leaking badly. And could I have closed that ASD percutaneously? Most definitely, high likelihood of success. But then you're closing the ASD percutaneously. Do you do the left atrial appendage first or later? Do they then
Yeah.
get the ability to have ablation? What do you do with the tricuspid valve? So the guy was super physically active. He went to surgery. He got his appendage taken care of, the ASD closed, and he got a ring on the tricuspid. And that gives him the possibility of having a valve in ring later should that fail. And I think that that needs to be individualized on every patient. But I think all of these cases that we're talking about speak to the strength of the valve team. And I think that, right now we're in a situation where the valve team is very one sided. If you're over 65, you get a valve team. If you're under 65 and you happen to show up at the surgeon's door first, you don't get a valve team. And I
Right.
don't think that there's any benefit in that. And I think it's our job to build trust relationships with the surgeons that they feel confident and comfortable to bring their patients to the valve team. And 98% of the time, probably the decision will be no different. They'll still get surgery, but maybe they'll get better surgery or they'll get, the right surgery or whatever. Again, if you have a younger patient that you feel doing a root enlargement or a root replacement is too high risk, um, then if you put a biological valve in there and that valve fails, they're probably going to be a lot higher risk to have an explant and a new biological valve put in, or uh, if they're not TAVR candidates. So if they're not TAVR candidates and you know that this is the one surgery you're going to get in that person, then maybe mechanical is the right answer. And I suspect partially that is why we're seeing a little bit of an uptick in mechanical valve usage. Paradoxically, small mechanical valves actually have lower gradients in some cases than biological valves. So if you feel the patient shouldn't be having a root enlargement or a root replacement, then maybe you put a mechanical if you don't want to put a TAVR.
Sure. Yeah, and I agree. I mean, I think it's, very important to have a good heart team. We get along great with our surgeons. We're not as streamlined as I'd like to see in terms of going through every case, having a CAT scan, going to see them together, but we usually come to the same decision. So, I think getting that streamlined is really important for all the valve programs. Final question I have for you, which you touched base on, is what is the patient preference, and how do we bring that into the mix? Because I think it's confusing for patients a lot of times. I don't know like how much, if they're clearly better one way or the other, how much, opinion they should have. Obviously, every patient wants TAVR. Just curious how you manage that, how you bring in the patient preference on these cases.
So I think that's a great question, and I think that it's a tough question as well because you said it, and our surgeons say it as well. Every patient wants TAVR.
Right.
I think the tough situations are where the valve team is not unitary. When you have a patient who shows up to valve clinic and somebody has poisoned the well and they told them, oh, you're going to go there, but you're only going to accept this. This is what you really need. Don't let them tell you anything else. That makes it really difficult. As you said, 98% of the time before I walk in the patient's room, I know what I'm going to say and I know what the surgeon is going to say because I looked at the CAT scan, I looked at the history, and it's generally we're in profound agreement with the surgeons on what we're going to do. Occasionally we get curveballs and we manage those in valve conference. But I think most patients by far are very reasonable. And if you have the cardiologist and the surgeon speaking with one voice or with two voices but saying the same thing, that's very powerful to the patient. And one line that I use a lot is, I tell patients, I say, look, I get paid a lot more to put a valve in you than to sit here talking to you, telling you that you shouldn't get a valve that I can give you and that you really should have surgery. And most people get it. For the people who don't get it, and for the people where we have a level of conviction that we should do maybe something else, we have to put those people on a spectrum because there are patients where we're going to say, absolutely, I don't, they say, I don't want what you're recommending. And it's our right to walk away to say, look, I'm not going to do that. I understand you want it, but I'm not going to do it because I think it's wrong and you can't make me do it. But then there are patients who fall in the middle and who are somewhere on the spectrum. And at that point, I think you have to strongly take into account the patient's preference and to take into account your level of comfort. And those are tough situations because sometimes the patient decision is not the one that you would want to have, and sometimes those patients can get hurt. And I think in the end, people are independent actors and they get to call the shots to a great degree. So I think, if all patients were following the guidelines, it would be very, very easy and everybody would get a lot of mechanical valves and whatever. But
Yeah.
everybody's life is different and that doesn't really work that way. And, you know, I think there's a role for mechanical valves, there's a role for Ross procedure, um, but in the end, you have to work with your patient and see what level of understanding you can come to. And I think it's much easier to do that when the valve team is unitary.
Yeah, absolutely. Absolutely. Well, Andrei, thanks for coming on. Awesome paper. I think it's a really challenging decision, to make with the patient, all the different things that go into it. And I think the framework you provided is actually a really good place to start. When I first read it, I thought it was complex, but it's really not. I think it's an excellent framework for us to approach these patients. So thank you for coming
Thank
on. I appreciate it.
Not a problem. Thank you for having me. And again, I think it's important to think in every patient of this and of the second valve that they're going to get in their lifetime. And I think we have most of the tools. We don't have all the tools, but I don't think we need a lot more to start making good decisions in these patients. So thank you for giving me the opportunity.
Yep. Awesome paper. Single sternotomy. Love it. Okay.
Single sternotomy. Take care.
Okay.
Bye bye.
All right, Andrei. Take care.